Everyone, I'd like to welcome you to today's webinar on new Medicare coverage for advanced orthotics and prosthetics. First off, I'd just like to say that the slide presentation or the slides from the presentation will be available on NAAOP's website later this afternoon. So don't feel like you have to take a zillion notes. This will be available later. Let me start with some introductions. I am Ann Moss, currently serving as president of NAAOP. Today's speakers include Peter Thomas, General Counsel and Managing Partner at Powers Law Firm, Nate Kappa, Certified Prosthetist from Bremer Prosthetics, and Vice President of NAAOP, and Taylor Haynes, the 2024 NAAOP Brees Fellow, and our founding Executive Director, George Brees. Let me sit. So we have a disclaimer on these presentations. So today's agenda is going to include purpose of this webinar, context for advances in O&P coverage, key coverage and coding policy advances, a Q&A at the end, and parting comments from George Brees. So I'd like to first off and welcome everyone to this webinar to discuss the expansion of the microprocessor knees to K2 beneficiaries with limb loss. Now this is a final coverage policy. Clarification that powered orthoses can be covered as orthoses under Medicare, expanding orthotic coverage. New HCPCS code for bone-anchored prostheses for osseointegration, and upper extremity prosthetic code clarifications to expand access. Let's see. First off, I'd like to really emphasize that we are stronger working together. NAAOP would like to especially recognize the O&P Alliance for their coordination of efforts behind the scenes. The O&P Alliance is made up of the Academy, ABC, AOPA, BOC, and NAAOP. All 5 of these organizations meet regularly and communicate routinely to represent the interests of the O&P profession with one voice. In attendance on today's webinar, we have representatives from all 5 of the national organizations to show support for the Alliance and what we have accomplished together. Each organization has been deeply involved in Alliance discussions on the 4 major topics we will be discussing today. Many others play important roles in the events that have happened, such as the Amputee Coalition, NCOAP, the ITEM Coalition, and others. In the case of the new microprocessor knee coverage policy, Ottobock deserves great credit for their hard work on this issue. Nate?
So next, we'd like to talk about the purpose of the webinar today. There's really 4 things that we're trying to accomplish with this talk. The first is to provide education to everyone here about the changes that have come. And it's really to think that these are advances in Medicare policy. These are things that, as clinicians, we're going to inherently see the benefits to our patients almost immediately when these go into effect. The next part is to understand how we comply with the documentation. Obviously, whenever there are changes in coverage, that is going to mean changes in LCDs and policy articles. We're going to really get into the weeds on some of that stuff to make sure that we understand how do we make sure that we get the best things to people and help them overcome their challenges. But then it's really important to notice also how these improvements are going to impact us today and in the future, and how did they come about? I mean, they really came about through, almost really decades of collaboration and research at this point that we're finally starting to be able to show the outcomes of how what we provide actually yields a benefit to these people. And the great thing is that the Medicare policymakers are actually listening to this. So hopefully it can kind of stem to another wave of more research so that those of us who work in advocacy can continue to seek more changes for our beneficiaries. And with that, I'll let Peter go ahead and start talking about some of these changes.
Thanks very much, Ann and Nate. So let me start first by saying that this webinar seems like exceptionally good timing, but we had called for this webinar at the end of June. Whether or not the microprocessor knee policy was published in final form or not. What we would have talked about is the draft policy, understanding that it was likely that ultimately that would make its way to the finish line in some form. But these changes that have been occurring at Medicare really over the last 18 months to 2 years have been pretty dramatic. And the reason we're having this webinar is to just make sure everyone is well aware of what has been happening with respect to the coverage, coding, and payment of orthotics and prosthetics in the recent past, so that you can take advantage of this to gain access to your patients for patient care. This comes in a context. This didn't just happen overnight. It's not just happening out of the blue for no reason. There's years of pent-up demand for advanced Medicare coverage of emerging technologies, clearly in the O&P space, but also in the durable medical equipment space and in other advanced medical technology areas as well. A lot of this was stymied in the DMEPOS area. A lot of this lack of progress had been stymied by concerns about fraud and abuse that occurred mainly in the 1990s and part of the early 2000s. And that really put a damper on Medicare or CMS's interest in moving forward with coverage of some of the policies that we're starting to see kind of the dam break on at this point. Investments in advocacy and research and building the O&P scientific evidence base, that's a key part of this. I recall very directly 15, 18 years ago, sitting with many of the O&P organizations talking about how we needed to focus on O&P research and development. NAAOP got its start in 1987 with ultimately supporting legislation that led to the National Center for Medical Rehabilitation Research. So this has come at over decades of research that has built the evidence base in orthotics and prosthetics. The recent administration's focus on health equity and elimination of health disparities is a major reason we're starting to see a lot of these policies come to fruition at this point. They're trying to take a look at the Medicare benefit among many other federal policies and make sure that people with disabilities are being treated fairly and equitably. They created a new technology coding and pricing group at CMS, which took some of the emphasis away from individuals who may have been recalcitrant to change in this area, and has really opened up the door to new advancements in this area. And finally, the coordinated and joint advocacy of NAAOP along with many partners, including those mentioned by Ann earlier in this presentation. All of that has led to a lot of these changes. Next slide. So let's get in and dig into the microprocessor knee policy. Obviously, this is a huge victory for Medicare beneficiaries, for other beneficiaries of other payers who will no doubt adopt this new policy over time. We're very confident that this will set the new standard for coverage. It's not a direct correlation, but it clearly will lead to advancements in private coverage as well, as microprocessor technology should be already, but will become really the standard of care. On January 18th, 2024, CMS published a proposed local coverage determination that would expand Medicare coverage of fluid, pneumatic, and electronic microprocessor prosthetic knees for K2, or what they call Medicare Functional Classification Level. They've created MFCL, I'll just call it K2, beneficiaries and above. Currently, these microprocessor knees are really only available for K3 and above. NAAOP, through the Alliance, submitted comments. We encouraged others to submit comments. We examined the policy closely. We strongly supported it. But at least 83 others submitted written comments, and many others submitted comments through a verbal open door forum. The final LCD for MPKs was announced just last week, last Thursday on the 18th of July, and the medical directors in CMS issued a local coverage determination in final form. They also issued a policy article that describes in more depth the parameters of this new policy and what needs to be documented in order to demonstrate medical necessity. They also published a response to comments, and there's a link to that in the joint statement that the O&P Alliance put out. It will be up on our NAAOP website later today. You can click on that link and examine what commenters said about this proposed policy and what the medical directors thought. I must tell you that the medical directors are pretty strongly supportive of prosthetists and the clinical expertise of this profession. We often grouse about how we're treated like DME suppliers, but I must tell you, read that document, and I think the message is getting across. There was one comment that even said that prosthetists should not be permitted to determine the functional level, that should be the purview of the physician and nurse practitioners and physical therapists. That was rejected explicitly by the medical directors. In fact, they cited the statute, which the Alliance worked on in large measure over several years to get past some statutory language that recognized the value of the clinical notes of the prosthetist and orthotist for purposes of demonstrating medical necessity of Medicare services. So all of these things are building upon each other. It's a strong set of comments and a very strong policy. And I think I just want to make sure people are aware that this is coming at the culmination of many, many years of active advocacy and policy efforts. So the local coverage determination in final form expands the coverage criteria for microprocessor controlled prosthetic knees, and I'm using that word to also describe fluid and pneumatic knees for K2 beneficiaries who are really pretty much defined as limited community ambulators and who require a prosthetic knee based on the best available medical evidence. This is an effective date. This policy goes into effect on September 1st of 2024. So your beneficiaries, your patients will be able to benefit from this at that date. I expect, and I would love to hear some comments in the Q&A section about what this really means for K2 beneficiaries. My assumption is that this is a huge advance forward. I think it's going to really mean a lot to Medicare beneficiaries who have not been able to access these technologies to date. Next slide. So the final LCD, new coverage focuses on the rate of falls, the risk of falling, the fear of falling, and gait performance with microprocessor technology. The policy is designed to provide MPK knees that detect when a user trips or stumbles or is about to fall and automatically adjusts to stabilize the knee unit compared to non-microprocessor knees in K2 amputees. There was a question in the response and to the comments that said, what about microprocessor knees that don't have automatic, that don't automatically adjust to prevent stumbles? They said those are not covered. It's very specific that you need to have stumble recovery as part of the knee in order to be covered under this policy. It also clarifies that not all non-microprocessor knees must be ruled out in order to provide a K2 amputee with a microprocessor knee. The previous policy, or the proposed policy, said that all non-MPKs must be ruled out before an MPK's claim is submitted. The DME MAC medical directors agreed with the comments from the NAAOP, the Alliance, and many others who said that standard is too high. That means basically trialing 200 other knees before you can get to a microprocessor. They clarified that that's not the case. In fact, they said trial and error or fail first policies do not apply here. You don't have to fail first. You just have to document why a non-MPK is not appropriate for this particular patient and why an MPK can benefit the patient in a variety of ways that we'll get into in a moment. The LCD also clarifies that a compatible foot is also covered that would typically be provided with an MPK knee. And that's another important policy that they didn't have to say that, and they went forward and did that. They have a series of modifiers that will need to be used. You need to really look at the at the policy article to really understand exactly what you do in terms of coding. KX essentially means that the beneficiary qualifies for the MPK and meets all the standards that are laid out in the policy article and the local coverage determination. I won't go deep into the other modifiers, but just take a close look at that language before submitting claims. Next slide. All right, documentation. This is key. In order to get your claims paid, in order to submit clean claims, you want the documentation to be right. And so the documentation must include how the MPK will improve the beneficiary's functional health outcomes. And the policy article goes into a fair amount of description of this. The LCD also describes exactly what needs to be demonstrated. Will it help the beneficiary accomplish their activities of daily living? Other lower level knee options have been considered and daily living and ruled out based on the beneficiary's individual functional and medical needs. So again, not all non-MPKs need to be ruled out, but the category needs to be ruled out. The microprocessor knee provided must be indicated for a K2 individual. In other words, the manufacturer has to determine that this is an appropriate device for a K2 amputee. There are some questions about who determines that in the Q&A section with respect to the response to the comments received by the DME Max. The DME Max clarified that the PDAC does not have to go through an independent process for every single MPK and determine whether or not they're appropriate for a K2 beneficiary. They do not, we do not need to have clinical studies, which was suggested by some of the commenters to demonstrate that a particular MPK knee is appropriate for a K2 beneficiary. They simply have to, the manufacturer's in charge of determining whether or not this knee is suitable for a K2 beneficiary. That's very permissive. That is a big improvement from the proposed policy, and we're glad to see that they adopted that. The beneficiary is able to make use of a product that requires daily charging and can understand and respond to alarms and alerts which require or that indicate knee dysfunction. These are components of MPK systems, and that's just something that the beneficiary needs to understand and have the capacity to address if, in fact, those alarms or alerts are sounded. Next slide. Functional levels are important. They've been in existence since 1994 or 1995. I remember working on them through NAAOP when they first came out. They largely have remained intact over the years, and they remain intact under this policy. But I must say that there are some new changes to the K levels that I think should be helpful. We're still looking at the real implications of the wording changes. And the O&P Alliance has not opined yet as to what we think about this, but certainly they, at first blush, they appear to be helpful. So when submitting a prosthetic claim for an MPK for a K2 beneficiary, the build code for a knee, foot, ankle, and hip, all the components must be submitted with modifiers 0 through K, the K system, indicating the expected level of the functional level of the beneficiary. And remember, the word potential is still in there. There must be information about the beneficiary's history and current condition, which supports the designation of the functional level by the process. Nothing new there. That's the same that's occurred for years now. The policy article, though, creates some new detail and guidance that physicians and prosthetists may very well find helpful regarding the selection of the functional level itself. We looked and we have not found the language that used to exist where they recognized special treatment for bilateral amputees. It appears that that's been removed. We're not sure why. It could be because they just simply got more specific about what the functional levels require, and they illustrated them through examples, and they don't feel that that's necessary to state any longer. But we will be going back, I expect, to the DME Max and requesting some explanation as to why they removed that language about bilateral amputees. Next slide. All right, so the medical records. Medical records, obviously, is what demonstrates medical necessity, and that's going to be an extremely important component to this. I'd like to turn the presentation over to Taylor Haynes, who is our 2024 Brees Fellow, to walk through some of the medical record requirements. Taylor?
Thanks, Peter. So this is really just expanding on some of the documentation requirements that Peter just went over. A lot of them we're used to seeing, but they go into greater detail. So the documentation of the clinical evaluation of this beneficiary's functional abilities demonstrated at a K2 level. So that word potential there really is just to highlight that this isn't necessarily what the beneficiary is able to do right at this present moment. It's what they might have the potential to be able to do going forward were they to get the MPK knee. And that is to say the MPK knee as well as fluid and pneumatic knees. So their overall medical health and the rationale for selecting an MPK, kind of a holistic overview of the patient is what they're hoping to have in the medical records. So which functional outcomes are expected to be improved. So if falls can be prevented, if it can help reduce energy expenditure, what specific outcomes are we hoping to ameliorate here? And which activities of daily living are we hoping to improve? And they want specifics. So if that's playing with your kids, your grandkids, being able to climb stairs, go to the grocery store by yourself or with assistance, working around the house. So what specific ADLs are expected to be improved here with the selected knee? As well as the documentation to support that non-MPKs. So as Peter noted, not all non-MPKs, but a justification that a non-MPK wouldn't work here for this specific beneficiary. Next slide, please. So some additional requirements here are the claims for an electronic or microprocessor knee for these beneficiaries at a K2 level must have some documentation that the integrated technology will help with stumble recovery, reduce fall risk. So an increased resistance in the knee, as Peter touched on earlier, to provide support to potentially avoid the fall altogether, but really just make the beneficiary more stable and safer ambulating out in the community. And as well as the cognitive ability to use an MPK. So being able to reliably charge the knee overnight or whenever it's necessary to, as well as responding to alerts, alarms, being able to recognize when the MPK is not functioning correctly, and making an appointment with their prosthetist to address that as necessary. Next slide, please. So this just kind of goes into some specifics of what K2 means. So we're all familiar with the K levels, but this just kind of goes into more specificity here. So again, that the individual has the ability or potential for ambulating low-level environments such as curbs, stairs, uneven surfaces. So typically we specify this as a limited community ambulator or a potential to be a limited community ambulator. So the specifics here are that they're able to perform level 1 tasks. This is just, again, cognitive ability to safely use a prosthesis, safe ambulation within the home, and then outside of the home, ability to ambulate on a flat, smooth surface. So, porch, deck area, concrete, pavement, things of that nature, and able to negotiate curbs and elevation change in surfaces of or low-level environment barriers. So that's curbs, 1 to 2 stairs, anything that's changing the elevation of the surface that the beneficiary is walking on. Ability to negotiate a ramp built to ADA specifications. So that's a maximum slope of 1 to 12, 1 foot of elevation change for every 12 feet, as well as being able to access public or private transportation, getting in and out of vehicles, things of that nature. Next slide, please. This just kind of highlights something that's a little bit different than the level 1 K level functional ability. So that they may require a wheelchair for distances beyond the perimeters of a yard, driveway, or their residence. Level 1 is indicated that a wheelchair is necessary for activities anywhere outside of the home. Additionally, that the beneficiary is only able to increase their walking speed for short distances or with great effort. So capable of variable cadence, but it might cause them to expend a lot of energy, or with great effort, they're able to do that, but not for very long periods of time. And then, the last piece here is that they're generally not capable of accomplishing K3 level activities at this time, but that they're currently or potentially able to meet all of those requirements that the functional abilities list for a K2 level beneficiary. Peter, back to you. You're on mute.
Thanks very much, Taylor. Great job. I just wanted to underscore that the last two slides that Taylor went through is really new. Those examples, are written in the policy article. It's new language. I encourage you to not only review and commit as much to memory as possible of that language, but use that language in your documentation, to send that new language to your physicians, your referral sources. Make sure they know the new K level descriptions, because I don't think they meant to change the K levels. In fact, they stated that in the DME MAC medical director stated that in their response to the comments. The K levels remain the same, but they've provided a fair amount of additional detail that I do believe will assist prescribers, therapists, and of course prosthetists in documenting the need for MPK technology. And if you can demonstrate that these beneficiaries require it, for functional and medical needs, you can gain access to those new technologies. So let's just kind of call it as it is. This is a huge victory for the field. This is going to transform access to MPKs for years to come. And not just with Medicare. As I said, Medicare has a sentinel effect. A lot of the private payers tend to focus on what Medicare covers and typically adopts that coverage over time. But that's not all. The MPK policy is a great advance, but there's been a number of other things that have occurred over the last 1.5 to 2 years that are really worthy of mention. That's, the MPK policy is a huge victory in the prosthetic space, but in the orthotic space, there's another huge victory, and that is essentially considering powered orthoses to be under the benefit category of orthotics. This was not a fait accompli. As early as I'd say a year ago, or say 13 months ago, we really didn't know whether CMS would determine that powered orthoses are considered orthotics or whether they're considered durable medical equipment, or maybe no benefit at all. CMS had a history of reading the orthotic definition, which is a regulatory definition, very, very strictly, basically suggesting that unless an orthosis supported a limb, it wasn't an orthosis. In fact, there was a history where they basically said that if you apply a force to a joint, especially through power, that doesn't qualify as supporting the limb. We quarreled with that definition and that interpretation of the language, but that's what they were saying. They signaled that they would regulate in this area, that they would add some additional definitions to the definition of orthoses. And they, in fact, put out a draft regulation last year, at the end of June. The O&P Alliance submitted comments, and they ultimately finalized the regulation largely as written. Bottom line, it's another great achievement, a new advance in coverage that I think ushers in a whole new family of powered orthoses, and many agree with me. So what I mean to say is I'm not alone. There's plenty of people that feel the same way. CMS codified the definition of a brace as a rigid or semi-rigid device used for the purpose of supporting a weak or deformed body member or restricting or eliminating motion in a diseased or injured part of the body. The O&P Alliance and NAAOP supported this definition. Why didn't we say this should be updated and made much more relevant to contemporary practice? Well, we did. If you read our comment letter suggested that this is old-fashioned language, deformed body member. This should be updated and improved. But frankly, what we were worried about was that if they change the definition of orthoses, we very well may have had the unintended consequence of requiring every single orthotic device that is currently coded to have to go through another coding verification process. And we did not want that to happen. We ultimately supported this language, but we encouraged them to ensure that the language surrounding orthotics was brought up to date and made more contemporary through the policy articles and the guidance that they put out. CMS also codified in that same regulation that a brace may include a shoe if it is an integral part of the brace and its expense is included as part of the cost of the brace. We were concerned that what they meant was that the shoe would not be separately reimbursable, that it was part of the reimbursement for the shoe. I'm sorry, for the brace. But they did not mean that. They, in fact, said that as long as a diabetic shoe or a shoe that's connected to a leg brace is connected for purposes of the function of that brace, it is a reimbursable shoe. Finally, the CMS clarified that powered upper extremity devices are lower limb and lower limb exoskeletons are considered braces. Next slide. So, as I said, the NAAOP and the Alliance did submit comments on this policy proposal. That was back in August of 2023, and the final policy did come out. They did codify the language that I suggested earlier, but we made sure that we urged CMS to interpret the orthotic benefit through contemporary orthotic clinical practice and language that would reflect that when making coding, coverage, and payment decisions in the future. We'll continue to monitor that, and we will look for new coding, coverage, and payment, as we have been over the past year and many years before that. We'll also continue working with the DME Max and CMS as they interpret the orthotic benefit going forward. I want to make a mention that of what this really means in terms of considering powered orthoses under the orthotic benefit. It means that essentially a whole new, I'll call it a family of powered orthoses is available for coverage, not only under Medicare, but eventually under by other payers. So the specific policy that the regulation addressed had to do with exoskeleton devices that assist people with paralysis to ambulate, usually with the use of crutches. These devices are getting more and more sophisticated. They are now capable of climbing stairs and descending stairs. They are now covered. They have a price point of around $100,000, which is a very significant price point for any orthosis. And ultimately, that's a big advance for the paralysis community. Exoskeletons are typically not prescribed, or I should say provided by orthotists, but it is an orthosis, and it is a big advance in coverage for Medicare beneficiaries with spinal cord injury. The other important specific set of devices approved through this regulation to be covered under the orthotic benefit were the Myomo type devices, MyoPro type devices. Ultimately, that we believe will lead to proliferation of powered orthoses as a result of this decision. And again, the price points on that were quite favorable as well. So we're really pleased. This is a big advance in orthoses. There were people in CMS who did not think that this should move forward as it was finalized. Felt very differently about this, but ultimately in the end, CMS did the right thing. And these are now considered covered benefits under the Medicare program. Next slide. Other advances include bone-anchored prostheses, what many people refer to as osseointegration. CMS established a new HCPCS code, 5991, Addition to lower extremity prostheses, osseointegrated external prosthetic connector to describe the Axor 2. That's the predicate product. The Axor 2 was determined to qualify under the prosthetic device benefit, and the average fee schedule was sufficient for the provision of this benefit. So we're very pleased to see that osseointegration and bone-anchored prostheses will move forward. Very important that Medicare covered that connector. There's additional work to be done that the O&P Alliance and NAAOP are considering. Next slide. So for instance, the one remaining concern is that there is no current base code for osseointegration. And there's some language that is concerning, that is in the policy documents, the policy article, that talks about no addition code. So we need to continue to work on this issue. But the fact that they have recognized bone-anchored prostheses is a big advance forward. For those beneficiaries in particular, for whom traditional socket technology really is not effective. More work needs to be done, as I've said, and we'll continue to educate or try to educate Medicare and other payers on osseointegration and try to come up with the best policies possible to ensure that people who need these systems get access to them. Next slide. Upper limb prosthetic coding and coverage. There was a coding document that the DME MAC medical directors put out that alarmed the O&P Alliance. We ultimately wrote to the DME MAC medical directors in June of 2022, and the Alliance submitted this letter on the upper limb coding guidance. We met with them in September of that same year, and in March of that same year, just after we met with them a second time, they wound up retiring the guidance on upper limb coding. Not all the guidance, but the most recent set of guidance was retired. That was a big victory in and of itself because it opened the door to some of the restrictions that have been put in place through that guidance. The new version of coding guidance, a new version has been drafted. The Upper Limb Society of the Academy took the lead on that. The Alliance vetted that information and ultimately will be passing that along to the DME MACs for their consideration going forward. We also have been working with that same group of folks, the Upper Limb Society, and they ultimately wound up submitting a new set of codes. Next slide. The upper limb code set really lacked any specificity and clarity with respect to partial hand prostheses. So there, just as of July 1, there was a multiple code set revision submitted. The Alliance endorsed this and vetted this proposal, but ultimately it was submitted by representatives of the Upper Limb Society of the Academy. And ultimately, we seek to have more than a dozen codes modified by including upper partial hand prostheses in the definition of the existing codes. That's phase one. There are additional phases to improve that code set overall, and we'll be working closely with that same group to try to advance that going forward. Next slide. Just as exoskeletons don't really involve orthotists, but do impact people with paralysis and Medicare beneficiaries with disabilities, so does seat elevation, except seat elevation is used by a fair amount of amputees who, for whatever reason, don't do very well with prosthetics or prostheses, or may do well in their homes and the like, but still require the use of a power wheelchair. Medicare for years did not cover seat elevation in power wheelchairs, especially in complex rehabilitative wheelchairs or CRT power wheelchairs. There is a coalition named the ITEM Coalition, stands for Independence Through Enhancement of Medicare and Medicaid. It's 100 national organizations, of which NAAOP is a member. And this ITEM Coalition is run out of our offices. I'm the co-coordinator of it. And ultimately, we submitted a request, a national coverage determination request back in September of 2020 to have Medicare cover seat elevation systems in power CRT wheelchairs. Finally, In May of 2023, Medicare decided in the affirmative, and they granted coverage for seat elevation systems. In the 6 or 7 months or 6 months that policy was in effect, just in 2023, over 5,000 Medicare beneficiaries received seat elevation systems. We're still working with the IDEM Coalition on the pricing to make sure that it will allow suppliers to make a reasonable margin when they provide seat elevation systems in power wheelchairs, and there's more work to be done there. But this is another big victory for Medicare beneficiaries with disabilities and does impact some amputees for sure. Finally, there's another NCD that's being put forward. It was also submitted on the same date as the seat elevation NCD, and it involves standing systems, power wheelchairs that rise into a standing position so that the beneficiary can unweight their posterior and improve bodily functions, respiration, motility, circulation, skin integrity, and the like. And that will hopefully be opened at some point in the near future for coverage consideration. Next slide. So that's our presentation. As you can see, this is not just an MPK presentation. Timing was great on that. Our alliance partners are on the phone, and we're all celebrating that victory. And again, I want to reiterate, Otto Bach deserves some real credit for really spearheading those negotiations and doing a lot of the heavy lifting in terms of the research and evidence base with others, for sure. That's what led to ultimately overturning that. The other thing that led to that is the 2016 failed and retired LCD for lower limb prostheses. If you recall, the Amputee Coalition, the OMP Alliance, NAAOP, a whole bunch of groups got really exercised over that and opposed that draft LCD. And what they wound up doing, the federal government wound up creating an interagency task force, which published a document that actually recommended that the Medicare program examine coverage for K2 amputees for microprocessor knees. And that's 7 years ago. And now the culmination of that just occurred last Thursday. So with that, we'll take questions through the chat function, if there are any. And we look forward to answering any of your questions you might have. If not today, then feel free to follow up individually with us, and we'd be happy to do so.
All right, we have a number of another number of Q&As put in. First one came in from Joe McTiernan, and he was pointing to the 2017 LLP CMS workgroup report that originally came up with the expanded K-level definitions, and Molly McCoy also provided a link to that. So that is going to be available in the Q&A section. I think I hit done, and that will be there for everybody. So thank you to both of you for pointing to that. That may be helpful. But Peter, do you want to comment on any of that?
Only that Joe and I have worked closely together, Joe at AOPA, and we've been talking about these K levels, over the weekend and, into this week. We still haven't, as an alliance, come to a formal position as to what these new K level descriptions really mean, what the impact of them will be. We don't love the fact that the bilateral language has been removed, but the rest of it sounds quite positive, and I think it will help people really understand to a greater extent what exactly is a K2 amputee, what exactly is a K3 amputee. And remember that word potential. It's not just how the beneficiary is performing in their current prostheses, assuming they have one. It's what do they have the potential to do if they're able to use a prosthesis that has advanced technological features.
There's two questions related to the same content. I'll sort of summarize both from David Falk and Shannon Dwyer. I want to know about K3 feet with a K2 amputee with an MPK.
Well, they don't say a whole lot about that in the policy, other than K3 feet will be considered compatible. They say compatible feet with a microprocessor will be considered for coverage. I think it's all going to boil down to how the write-up and how the documentation looks and why you need a particular foot to accompany and to be compatible with an MPK, pneumatic, or fluid knee. They clearly signal that in the policy, although they don't say a whole lot about it. So we might want to follow up with the DME-MAC medical directors. I encourage you to read all of the documents, the LCD, the policy article, and the comments to the responses. I got a lot out of the comments because, frankly, they were really quite positive and bullish on prosthetics and the clinical nature of prosthetics. And we often, as I said at the beginning of my talk, we often grouse about how we're treated like DME salesmen. It doesn't seem that way when you read through those responses. I think they really do appreciate the fact that and recognize the statutory language that the prosthetist's notes and documentation is a very important element of demonstrating medical necessity. Nate, do you have anything you'd like to say there, or Ann?
I mean, I think that, kind of what you said about the compatible foot with the microprocessor knee is an indication that we will have to show that why a certain foot is necessary for the knee to function the proper way. But as we all know, a flexible keel foot or a foot we would typically use in a K2 patient is going to be contraindicated for a microprocessor knee.
All right, I'm going to move on to the next question. This is comment, but I'll phrase it in the form of a question from Carl Lindbergh. The MPK K2 LCD's update is great progress for our field. Can NAAOP provide any insight on how to prevent potential abuse of this new LCD?
Well, I'm so glad you raised that because the last thing we need is to have this policy extended in good faith, and then for us as a field to abuse the policy and to basically slap an MPK on every amputee that walks in the door. We can't do that. We have to police ourselves. We have to be responsible. Expect audits. Expect increased scrutiny if we wind up abusing this benefit or not detailing the notes, the clinical notes in an appropriate manner. Expect recoupments. That will occur if we're not careful. So I can't stress enough the point. I guess I'm chagrined that we didn't include it ourselves in the slide deck. It's a critical point. This is a big victory, but it comes with responsibility. And I implore prosthetists across on this call and across the nation to make sure that they are responsible in terms of who gets access to these technologies and documenting well according to what Medicare requires, so that we don't have a backlash and we don't have a whole new spate of audits and appeals to deal with as a result of this.
There was a second part to it where he mentioned that suggestions would be to partner with physical therapists and PM&R to assist with proper rehab protocols to strengthen these more fragile users of prosthetic technology.
I would never speak against collaboration with respect to medical rehabilitation. That's the underpinning for the way the best rehab is provided. If there are ways that you can partner with physicians and therapists to become part of a rehab team where the prosthetist is largely responsible for exactly what they do today, but in the context of a more integrated rehab team, I personally am all in favor of that. And I would think that anyone really who understands rehab medicine would be in favor of that. I do think you'll help. That will help the other providers, the prescriber, the physician, the therapist, document their notes in such a way that it will only bolster the chances that that prosthetic claim is not only paid, but stays paid and is not reopened and recouped. So I would strongly encourage that. And I think that's a great model to try to aspire to.
There's another question. Two people asked a very similar question, both Jim Andreessen and let's see who else asked. Shelley Hogan, we're asking about Medicare HMOs, Advantage plans. Are they going to be downstream required to provide these services as well?
And not even downstream. As of September 1, this benefit applies to MA plans 100%. And now we have an interplay between our previous webinar that NAAOP put on, which was about the Medicare Advantage new rules that went into effect January 1. That too is available on our website, and I encourage you to take a look at it if you haven't seen it. There's a whole new set of requirements that are in regulation that Medicare Advantage plans must adhere to, and one of the key requirements is that they must cover the Medicare benefit package, LCDs, NCDs, statute and regulation that all applies to MA plans. Now, will they continue to use prior authorization? Will they continue to seek to deny claims to figure out ways to get around the benefit? I expect they will, but there are a lot of tools available to prosthetists and orthotists to use to force their hand to ensure that they comply, to cite chapter and verse on the regulations, all of which is in that slide deck that NAAOP now has provided twice, last summer and earlier this year. And I encourage you to use those rules to try to push back if they start denying claims. These rules equally apply to Medicare Advantage plans.
And those are available in at the NAAOP website. If you look at the blog section where the news, you'll see the recordings from those previous webinars that Peter's mentioning. Two more questions that are similar. Both Joe McTiernan mentioned and then Jim Fenton from Florida mentioned required Medicare prior authorization for MPKs. Should we be prepared for them? And Joe mentioned that they would reduce chances for fraud and abuse. Any commentary on pre-auth for K2 MPKs?
Well, as most people are aware, Medicare, the CMS did implement in the fee-for-service program prior authorization for certain prosthetic components. I believe they extended it to some orthotics as well, but still fairly limited. The Alliance was concerned that that was kind of a DME concept that was being applied to O&P and was a bit alarmed by that. But frankly, what we've seen over the last couple of years is that folks in the field have generally gravitated toward prior authorization as a better option than providing the prosthetic care and then realizing that the claim has been denied or recouped or reopened and fighting through the appeals process that typically takes sometimes years. And so we found that most people are comfortable with prior authorization on some of the higher end components. And if the DME MAC medical directors went forward with some additional prior authorization procedures for K2 amputees, A, I wouldn't be surprised. And B, I don't think and I don't think the Alliance fears it as much as or is concerned about it as much as we used to be because of the feedback that we've received from the field. Prior authorization is not in the abstract. It's compared to what? And when the other alternative is to pay the manufacturer for the prosthetic component, provide it to the patient, and then have the claim either denied or recouped after the fact and have to go fight that appeal, that's typically a worse option.
Right. There's another one, Ronald Johnson and Sarah Stilley, both questioning the MPK and powered wheelchair. Does the provision of a powered wheelchair affect MPK delivery? If they have a powered wheelchair, can they get an MPK, or is one going to exclude the other?
There's not a whole lot that Medicare said about that. I would make a full-throated endorsement of the fact that some people with limb loss require both a power wheelchair and a prosthesis or more, if they're bilateral, if they're multiple amputees. I'm not so sure that the CMS has said much about that. There's not that many people in that position, but I also haven't heard that that's a major problem. So I guess at this point we'll leave it at that. I want to make sure we get to George Brees, our founding executive director, to share a few points about NAAOP. Paul, are we ready to move on to George?
There's a lot of about 7 questions left. Do you want to try to squeeze a few more in real quick?
Why don't we let George speak, and then we can continue going for, I suppose, as long as people are willing to stay, or we can answer them in writing.
Yeah, sounds good.
Thank you, Peter, and thank you, Ann, Nate, Taylor, of course, Paul, NAAOP. I really want to thank the folks who attended today's webinar. We appreciate you. And I want to say to our members, those who are members of the NAAOP, thank you so much for the trust you place in our efforts. It means so much to all of us that you see here on the screen right now, and to all of our members. And of course, I'd like to especially thank those that Ann mentioned early on, the other associations and organizations that we work with every day on behalf of folks with limb loss and limb difference. That doesn't a day go by that they're not on the tip of the spear in our thought process. And so if you're not a member of NAAOP, I encourage you to go to our website. On our homepage at the bottom, you can securely join the NAAOP and our advocacy efforts. Also, if you wish, make a donation to the NAAOP Fellowship. And Taylor, we can't thank you enough for what you've meant to this year's fellowship. Today is just another example of the leadership and the great future that you have in your profession. So thank you all again for participating today and for joining us in this webinar. And again, if you're not a member, if you can see your way to join, we would be most grateful. Thank you so much. Paul?
All right, we'll carry on with some more questions. Thank you, George. The QR code on the screen will take you right to the membership page. 2 clicks and we'll charge your PayPal or credit card. And thank you for your support. Okay, a few more questions here. One, what do you see are the next steps? This is from Christopher Hoyt. What do you see are the next steps to obtain reimbursement for time, intensity, and expertise for bone-anchored prosthetic care without a base code?
That's a great point. We're looking at that. I've been looking at some of the language in the existing LCA that talks about no add-on codes. This is the entire device. It's troubling language. I think we need to examine that. I think we need to go back to the ultimately support whatever efforts there are to go back to that. I mean, largely the companies involved in osseointegration and bone-anchored prostheses are going to have to take the lead, just like Otto Bach took the lead on MPK coverage. But the Alliance plays an important role. NAAOP plays an important role in supporting those efforts and doing what we can to try to push Congress and push ultimately CMS to continue to allow access to bone-anchored prostheses. And if the current policy remains in effect alone, I'm not sure that that does it. We clearly have an agenda in the bone-anchored prostheses area that we're going to have to continue to pursue. I think it's great news that we got, ultimately the field got a code for osseointegration, but we need to do more.
All right, thanks, Chris. Julie Palmer wants to know, she understands DME Max retired the coding guidance, but have they removed the edits for claim processing?
I believe they have, but I don't have confirmation of that because I don't submit claims. I haven't heard that that's a problem. The problem that I've heard is that while they removed that coding guidance for upper limb prostheses, they left intact previous guidance that said some of the same things that was ultimately in the guidance they retired. And so there is some confusion, to be honest, about exactly what should be billed and what can and cannot be billed. But my understanding is that that the the edits have not been an issue. I could be wrong. There might be some on the phone call who know more information than I do. I'd be happy to try to follow up. But at least from my perspective, that's not been an issue to date.
Brian Califf speaks on powered orthoses. It was mentioned that CPOs aren't typically the provider of these interventions. Any reason a CPO should not be the provider of those existing and future interventions? And also great advocacy work by NAAOP and the Alliance.
Thanks so much. We appreciate that. No, I think there is no reason why orthotists should not be getting into exoskeletons. Although I do think that the company or companies that function in that space, LifeWord is one company, Exo Bionics is another company. Harker Panafin used to be involved, but I believe they're no longer involved. They typically work through physical therapists, but I must tell you, because it's an orthoses, there was no clarity as to whether it would be considered an orthoses or durable medical equipment. In fact, it originally was deemed durable medical equipment, and it was being paid by Medicare on a rental basis at a very, very low price point, an unsustainable price point. So CMS turned that around and now has ultimately made that a viable benefit for those who qualify. I do think that orthotists play a role in exoskeletons, and especially now that it's deemed an orthoses for purposes of the benefit category, I see no reason why orthotists should not make efforts to try to get involved in that and to try to be part of the team that provides that care to people with spinal cord injury.
Thank you. John Schrader wants to know, are there still plans to push for separation of DME from O&P for policy issues and reimbursement?
Great question. The way I always answer this is first, let's look at what the differences are between them. There are different sections of the Social Security Act, 1861 S9 versus 1861 S6 for durable medical equipment. Prosthetic devices are 1861 S8. This may not mean much to you, but ultimately those are different categories or different sections of the law. So there is different treatment. There's different treatment with respect to the surety bond requirement, with respect to the application of the quality standards, with respect to accreditation requirements. CMS, in fact, does treat O&P and DME differently. The section of the regulations contains both. We tried legislatively through the O&P Medicare Improvement Act, which was the earlier version of the Patient-Centered Care Act, to legislatively separate the two, but wound up realizing that the PTs and the OTs felt as though maybe they could eliminate the effects of BIPA Section 427, which was passed in 2000, by getting explicit authority to be treated as prosthetists and orthotists are under the Medicare program, thereby eliminating those protections from BIPA 427. It gets a little complicated, but they were using the ability or our attempt to separate DME from O&P as a sword instead of a shield. So we can continue to work, and the Alliance's position is that we are continuing to work with CMS directly to try to make sure that orthotics and prosthetics is separate and distinct from durable medical equipment. But I must tell you, there already are very significant differences between how we're treated and how they're treated. The main concern, of course, which is on everyone's mind, is how can we get reimbursed as clinicians? How can we get reimbursed for our time, for our expertise, for the intensity of the care that we provide? That is an ongoing discussion. It's not an easy answer, and it requires, it's kind of the parable, the grass is always greener on the other side of the hill, over the fence. The bottom line is we don't have any simple or easy answers to get that accomplished. But the debate continues, and we look forward to continuing that and continuing to hear from the field to see if we can make progress on it.
Right, David Palenko wants to know, are there any specific assistive devices that the K2 amputee can perform ADLs with? Was there?
There's no limit. It always says throughout the policy, with or without assistance, even personal assistance, the use of another person. So canes, crutches, walkers, there's no limitation in what that assistance really is.
Carol Gray asks, I'd never heard that distinction regarding K level 1 and 2 with the wheelchair use. Can you provide the reference source? There was the statement that you made from the policy regarding the wheelchair use earlier.
I think you're talking about, I'm not sure exactly what you're talking about. You may be talking about whether an amputee can both receive a prosthesis and a wheelchair. If that's the case, I think if you can demonstrate that a person cannot sufficiently ambulate and perform activities of daily living with a prosthesis alone and needs a wheelchair, but that a prosthesis would help them with transfers or household ambulation. If you write that up appropriately and document that, I don't see any reason why there's certainly no bar that I know of that says if you get a prosthesis, you can't get a wheelchair. If you get a wheelchair, you can't get a prosthesis. I'm not aware of any bar in coverage that explicitly states that. I hope that I'm addressing the question you're asking.
I think it's also in the definition of the K levels now, correct? Right? The clarification, it addresses the wheelchair use for.
Maybe that's what she was referring to, but my apologies. Yeah, I don't know what the reference is. That's the DME Max have proposed new language and finalized new language. By the way, that was not proposed. We did not see any K level proposals in the LCD proposal earlier this year. And so we didn't respond to anything because there was nothing to respond to. The changes to the policy article that include the additional information around the K levels is new. That's one of the reasons I've said twice, and now I'll say it a third time, NAAOP and the O&P Alliance has not yet come to a conclusion or a position on how we feel about that additional language.
There were two similar questions from Matt Scogan and someone named Darren were asking regarding, let's see, I'm very pleased with this, as most transferable amputees we see are K1 and K2. Does this just follow all the standard documentation needs? Are there any additional forms or tests? And then Darren mentioned that variable cadence was a big qualifier for an MPK as a break between K2 and K3. What is something that's now similar from the K1 to K2 differentiator?
It's a little difficult to answer that question. The reliance on variable cadence does not appear to be the dispositive issue any longer, if that's the way you interpreted it before. I guess I would just simply refer you to the new language. The policy article is very explicit in terms of what those different K levels, how they're illustrated, what they represent, and the LCD itself is very specific as to the documentation that's required. So I just commend you to those documents. And again, the comments to the responses to the comments that the DME Max published is also available on the NAAOP website. I know AOPA distributed that. I expect the Academy is distributing that. You can click on that, and I'd read that as well. I think it's very instructive.
Any specific MPKs that be given to K2? Do the clinicians have any specifics they want to identify that meet those criteria as what they're looking for?
It's kind of smacks of a bit more of a clinical question. I can tell you that manufacturers are the ones that determine whether a microprocessor knee is appropriate for a K2 amputee. That's potentially a big change from the proposed rule because it wasn't clear whether or not the manufacturer made that decision or whether there had to be some independent process through the PDAC or through clinical studies or the like. The final determination was made that the manufacturer determines what MPKs are appropriate for K2 amputees. if that was the question, that's the answer. But a lot of the answers to these questions are in the documents that they've sent around.
I think another thing to note on that, Peter, is that the microprocessor has to have stance phase control.
That's
So it
true.
has to offer the stumble recovery.
Very important. They discussed that in the comment and response section as well.
All right, last one is related to this policy, L5856, L5857, L5858, L5973, L5980, and L5987 already require prior auth. Should we assume it would still require prior auth when being provided for a K2 patient?
I would. I don't think there's anything here that suggests that that those prior authorizations requirements have been lifted. I think you're much safer if you assume that those still are in effect.
And there was one more question related to AFOs, but I could take that, get the information from this person offline. It's really about billing for 1932 and 1951. I think it's out of the scope of this lecture today, but I've got your information and we'll forward it off to somebody who might be able to help you, Jennifer.
Well, we're 10 minutes over, Paul, so I think maybe we should wrap this up. Last word, Ann or Taylor or both?
I'd just like to say thank you, everyone. And again, these slides will be posted on NAAOP's website for reference later and for any additional of staff or colleagues that you work with that you would like to share. Thank you very much. Taylor, you want to say anything? This is your last week.
I know. Yeah, I so appreciate the opportunity to speak today, and I have appreciated everything I've been able to do because of the NAAOP Brees Fellowship this summer. I've just had the most extraordinary 10 weeks, so I'm very grateful, and I will hopefully be seeing everyone in the months and years to come. So thanks so much.
Thanks,
Thank you,
everyone.
Thanks.